Welcome to the Jack Joseph and Morton Mandel School of Applied Social Sciences and the fourth of our Centennial Research and Training Colloquia series this academic year. My name is David Beagle. I'm chair of the Mandel School's doctoral program, and I'll be introducing today's program on behalf of Dr. Elizabeth Tracy, who's professor and associate dean of research and training at the Mandel School and the organizer of our colloquia series. This colloquia series is co-sponsored by the Office of Research Administration and the doctoral program at the Mandel School. The list of colloquia this year is in the lobby when you registered, and you're welcome to come back for any future sessions. A few logistics. Restrooms are down the hall off the lobby. CEU certificates and the sign up for professional development hours for social work students are in the lobby. And some well-deserved thank yous to Ina Brand, Carm Gambates, and Tracy Bradnan for their help with this series. For the question and answer time, we will be using a portable microphone, so please wait for our doctoral student, Jiho Park. Jiho, you want to wave your hand so people know? She will walk around the mic before you start asking your question. A warm welcome to the many viewers connecting remotely through our live streaming. If you are one of those, you can email questions online to Mandel School, that's one word, mandelschool@case.edu. Our centennial theme for this year is featuring our own Mandel School's cutting-edge research. Today's topic, consensus-based assessment tool of community readiness and capacity for farmers market implementation, is presented by Dr. Un-Lai Lee, a postdoctoral scholar at the Research Center for Healthy Neighborhoods and a graduate of the Mandel School's doctoral program. Dr. Darcy Friedman, Associate Professor, Department of Epidemiology and Biostatistics, and Associate Director of the Research Center for Healthy Neighborhoods. And Dr. Jared Dalton, Assistant Professor of Medicine, Cleveland Clinic, Lerner College of Medicine. At 2 p.m., after this presentation, you have an opportunity to meet with the presenters, today's presenters, and that will be in room 114 at the end. And now, please join me in welcoming Dr. Un-Lai Lee.
Thank you very much, Dr. Beagle. Good afternoon, everyone. This is a great honor to be here, and I'm very excited about sharing our research with you. And today we are going to present our consensus-based modeling approach we use to develop a web-based tool of community readiness and capacity for community nutrition and public health practitioners who are interested in implementing farmers market intervention to address obesity among low-income populations. First, I would like to acknowledge the funders of our study, the Building Capacity for Obesity Prevention. We call it BCOP study. It's supported by CDC and USDA. Before we share our research with you, I'd like to give you an overview of our presentation today. So first, I will talk about some background information about obesity burden in our society, and then Darcy will introduce you to our BCOP study. Next, I will come back and present our consensus-based modeling approach that I just mentioned before, and Gerard will then talk about the scoring system of the assessment tool. We named it Farmers Market PSE READI, and he will also explain how this tool works using simulated scores and recommendations. Lastly, Darcy will talk about contributions and implication of our study, as well as next steps that we are currently working on. And we are happy to answer your question after our presentation. As you may already know, obesity continues to be of great health concern in the United States. The Centers for Disease Control and Prevention have monitored obesity trends over time using telephone-based representative population survey, the behavior risk factor surveillance system. You can see on the top left, few states had a 15% or more prevalence of obesity in 1990s. And around half of the state, moving to the right, many states had a 15% or more prevalence of obesity in 2000, and around half of the states had 20% or more as their obesity prevalence. If you see the map on the bottom, many states had a prevalence rate of 25%, and several states had a prevalence rate of 30% or more in 2010, indicating a shift in this 20-year period, a shift in increasing obesity in all states in the United States. And according to the most recent data, BLFS data, more than 1/3 of adults in the United States are obese. And this map shows the most recent data. So again, more than 1/3 of adults in the United States are obese, and which is 37.7%. And obesity prevalence in 21 states and Guam, those with orange color, was 30% to less than 35%. 4 states, Alabama, Louisiana, Mississippi, and West Virginia, had an obesity prevalence of 35% or more. And do you know Ohio? It was 29.8% in 2015. More serious problems regarding obesity is the fact that it affects some groups more than others. For example, these 3 maps clearly show obesity is more prevalent among ethnic minority populations. Combining BRFSS data from 2013 through 2015, non-Hispanic Blacks had the highest prevalence of obesity, which was 38.1%. For Hispanic, it was 31.9%, whereas 27.6% of non-Hispanic whites were obese. In addition to disparity in obesity epidemic by race and ethnicity, it is well known that obesity rates are highest among low-income Americans compared to those with the highest income. Since obesity is deeply related to dietary behaviors, I think this figure gives us an explanation on why obesity rates are higher among low-income populations. Wang and colleague investigated trends in dietary quality from 1990 through 2010 in the U.S. adult population using the data from National Health and Nutrition Examination Survey. They used alternative healthy eating index, a 11-dimension dietary quality index, including the intake of fruits, vegetables, whole grain, nuts, and red or processed meat. And socioeconomic status was measured by both income and education. So key findings are dietary quality in the high SES group is consistently higher than in the lower SES group. And the improvement accelerated over time. In contrast, in the low SES group, no significant temporal trends was observed. As a result, you can see the substantial gap in terms of dietary quality between the high SES group and the low SES group. Lastly, obesity is associated with various adverse health conditions, including heart disease, stroke, type 2 diabetes, and sometimes some types of cancer. For example, Willett and colleague summarized the relationship between BMI up to 30 and relative risk of 4 comorbid disease, which are type 2 diabetes, cholelithiasis, it's a gallstone, and hypertension, and coronary heart disease. As you can see, the relationship between BMI up to 30 and the comorbidity disease are linear, both for women and men, indicating the higher BMI scores, the greater risk of these 4 comorbidity disease. Particularly, the risk of diabetes was 4 times as high in men with a BMI 26 and 8 times as high in women with a BMI of 26 compared to those with a BMI of less than 21. So obesity is a critical contributor to this comorbidity disease. In fact, the estimated annual medical cost of obesity in the United States was $147 billion in 2008, and the medical cost for people who are obese were $1,420 higher than those of normal weight. So weight gain and obesity develop from an accumulated period of energy imbalance between how much energy we take in through what we eat and how much we expend through our total physical activity. So when it comes to the prevention of obesity or weight gain, there has been a prevailing view up until recent times that as obesity develops from an energy imbalance resulting from our own personal dietary and physical activities, physical behaviors, interventions to address and prevent obesity should target individual behavior change. In some ways, it is supported. However, there has been a growing consensus that social environmental conditions have also played a critical role in obesity epidemic, meaning there are social environmental conditions that hinder people from having healthy food and being physically active. For example, in some communities, access to healthy and affordable foods are very limited, which may lead to the intake of unhealthy, calorie-dense food. You know, food desert. In this sense, there is a strong need for population-level interventions that change broader social and environmental factors. Particularly, our presentation today focuses on one of population-level nutrition-related intervention, and that is farmers market.
Thank you, Unlay, for a really nice setup to the BCOP study. So BCOP, Building Capacity for Obesity Prevention, is a collaborative study between researchers and practitioners. And in particular, we have teams from Case Western, from the Ohio State University in particular with their extension program and their SNAP-Ed program, and I'm going to talk a minute about SNAP-Ed, and the Ohio Department of Health, and in particular with their Creating Healthy Communities program. So SNAP-Ed is a program, is a national program in every state and territory in the country, funded to improve nutrition, among low-income populations. And their target population for SNAP-Ed is people receiving Supplemental Nutrition Assistance Program benefits, or SNAP, formerly food stamps, or SNAP eligible. So low income that may not be receiving it but would be eligible to receive. Historically, SNAP-Ed has focused on direct education as its primary strategy. And in a minute, I'm going to talk about how they've shifted their focus to address some of what Unlay was talking about around population level or community level influences of obesity. And the Creating Healthy Communities program is operated through the Ohio Department of Health in about 24 counties across the state. And these individuals, Creating Healthy Communities staff, are working within health departments to specifically focus on policy, environmental systems level change within the neighborhoods or within the communities around reducing risk for obesity. So it could be physical activity or it could be nutrition. In fact, in Cuyahoga County, we have both SNAP-Ed and CHE programming. And here's a picture of our team at one of our consensus modeling meetings. So the focus of our project was to come together to identify key aspects of community readiness and practitioner capacity for obesity prevention, and specifically around community level prevention. And ultimately, our goal is to inform and influence practice among the SNAP-Ed practitioners and the public health practitioners by developing tools that will optimize success in their communities, specifically related to implementing nutrition-related policy system environmental interventions, or PSEs. You'll hear me say PSE. So as I mentioned a minute ago, SNAP-Ed has had a fairly dramatic shift in its orientation in the past 5 or 6 years as a result of policy level change. So in the Healthy Hunger Free Kids Act, there was stipulation that half of the efforts of all SNAP educators across the country over a period of a decade needed to shift from being direct education only, so that would be convening a group of people together to learn about the food pyramid, to policy system environmental level change, and really building on the reality that many communities where we see disproportionate burden of obesity are contexts where it's very difficult to find a healthy product or a playground. And so the Healthy Hungry Free Kids Act made a major impact on the program. Secondly, the Farm Bill that was passed in 2014 also further enforced that focus of SNAP-Ed on PSE interventions. So if you think about it, and I know this is a social work space right here. We have a practitioner base that was trained to deliver direct education, to teach you about the food pyramid. That is a single practitioner implementation process. I can set up a room, I can invite you to come, and I conduct the whole session and not coordinate with one other person. But when we're talking about implementing policy, system, environmental change, I don't care if you're the absolute best change agent from MSAS, you're not going to be able to do it on your own. You have to become a coordinated practitioner. And secondly, it doesn't matter how good you are. If your community is not ready, it doesn't matter. We have to match the intervention with the community context. And so that's really the impetus behind our project, because it's one thing to recommend that practitioners shift their focus. It's an entirely different thing for them to actually make the shift. And ultimately, we really come in with an asset-based model that practitioners could be successful if they plug in at the right space along the implementation highway. However, if you plug in at the wrong place, you really risk demoralization of your practitioner base, because there's a lot of opportunity for failure. And it's not just failure on your own. You set up a class and nobody showed, which maybe nobody would know about that. but it's failure in a community, a very public space. And so, one of our goals in developing this project was to figure out how do we collaborate and provide the resources to hopefully optimize success. We specifically focus in BCOP on 4 PSEs, 4 nutrition-related PSEs. Farmers markets, which you're going to hear a lot about today. We also focus on healthy eating policy and childcare. So that would be something like establishing spaces for breastfeeding, or strategies to not serve fried food within the daycare setting. Healthy food retail, that would be, for example, corner stores offering more healthy food products, or grocery stores having a checkout lane that didn't have any candy in it. And then farm to school would be programs where there's a link between, for example, a garden in a school, or locally grown food being incorporated into the school cafeteria. We've developed everything you're going to hear about today. We've replicated with each of those. We're going to use the farmers market as the example for our conversation. Just so that we're all on the same page, when we talk about farmers markets, has anybody ever been to a farmers market? A lot of people in the room. Farmers markets have been identified, and I should have noted there, we picked these 4 PSEs because multiple organizations, including the Centers for Disease Control and Prevention, the USDA, the World Health Organization, and numerous others, have identified these 4 as strategies to improve affordable access to healthy foods within communities. So we didn't pick these as our own ideas. They are being recommended as evidence-based interventions. So in terms of farmers market PSE projects, we're specifically talking about getting SNAP or EBT, electronic benefit transfer systems, within the farmers market space. Currently, less than half of all the farmers markets in the country offer SNAP EBT, which means that if I have SNAP benefits, I would not be able to purchase food at that farmer's market unless I was going to use cash. Secondly, developing incentive programs to increase affordability of healthy foods. Many of you have probably heard of the Produce Perks program in Cleveland. Actually, Amanda from OSU Extension back there, do you want to raise your hand, is the manager of our program here in Cuyahoga County. This is a program that matches SNAP dollars at a farmer's market to double the value of your SNAP benefits up to a certain amount. In Cleveland, it's for every $10 you spend in SNAP, you get $10 matching to buy fruits and vegetables. Supporting efforts to grow the supply of farmers to vend at farmers markets. So these could be farmer development programs. For example, in Cleveland, we have a refugee farmer program. That would be one way of investing in those kinds of programs. And then tailoring outreach and nutrition education and skills training to increase demand for farmers markets. So for example, when you're doing that nutrition education class, which we know SNAP educators are doing for at least half of their time, are you talking about farmers markets as a place to buy the foods that, for the recipes we're talking about, or about the value of that nutrition incentive program? So we use a mixed methods process where first we collected qualitative data, and Unlay is going to go through our full process in a minute. And the qualitative data informed the models that were essentially decision models that we are created. So importantly, even though these are evidence-based recommendations, we wanted to go from the people who were going to be implementing the programs and people who are the intended beneficiaries of the program to understand from their perspective, what does it take to make this successful in the community? Once we collected the qualitative data, analyzed the qualitative data, we got feedback from our community partners, experts, to identify which of these factors are most important for implementing the 4 interventions, so for implementing farmers market PSEs. And that's what ultimately, and you'll see in our scoring, we didn't just say, here's a list of all the things you could do, but there's actually a ranked list within there. So hopefully it will ultimately lead to tailored recommendations to guide practice within the community. So I like this figure here because I think it gets at the heart of what BCOP is about. This idea that we have, and I think we could probably all relate to this idea, we have evidence-based recommendations on the one hand, and there are so many. I mean, we need more, but there are a lot of evidence-based recommendations. And then we say, you know, put those into practice. But we don't have a lot that goes on in what I call that pre-implementation phase. What does it take to become ready? And I think one of the big critiques of evidence-based practice is that the communities that perhaps need these interventions the most have a lot of gap between recommendation and implementation, and their likelihood of success and ultimately, you know, achieving the goals of those interventions is potentially limited. And honestly, I think a good risk of evidence-based practice is a widening of disparities rather than a narrowing. And so that's really the heart of our BCOP project, is how do we make sure that the community that perhaps needs it the most is able to take advantage of these interventions and really maximize success. And so I'm going to go ahead and turn it back to Unlay to talk about the consensus-based modeling approach.
So thank you, Darcy. How do we develop this tailored assessment tool? The answer to this question for us was to use a multi-phase consensus-based modeling approach. And one of the key characteristics of our approach is to develop tailored implementation strategies based on the realities of community readiness and capacity. And as Darcy mentioned, we included both community residents who are potential recipients of the intervention, as well as practitioners who will be the end users of this tool during the process of our consensus modeling. In addition to that, our approach included a multi-phase iterative process of action and reflection. It took so long time to develop these assessment tools, and I'm going to talk about it in a minute. So our process of consensus-based modeling involves 5 phases, and I will briefly summarize them, and then we'll give you detailed information on each phase. And as Darcy mentioned, our BCOP study is a mixed method study. So we started from collecting qualitative data from community residents and practitioners, and then developed indicators based on the findings from this qualitative study. We had a consensus conference with farmers market experts, and we refined our indicators based on the findings from this consensus conference, as well as pilot testing. I said that our modeling approach is an iterative process because it includes really ongoing back and forth process of action and reflections. So for example, when we refined our indicators and themes based on findings and feedback from the panelists who was in our consensus conference, our research team not only met many times and discussed about them, but also we went back to our qualitative data to make sure whether our data also support that change. So let's talk about each phase in detail. So in our first phase, we conducted 18 in-person and 23 focus group interviews with 194 community residents and practitioners in 9 counties, Ohio, between April and June 2015, in order to understand facilitators and barriers for successful implementation of farmers market intervention. These 9 counties were purposefully selected because they had on-the-ground CHC and step-ed staff to support farmers market intervention. Also, these 9 counties represented diversity in terms of county health ranking, geographic location, urban and rural areas, adult obesity rates, and SNAP participation. In terms of data analysis, I taught this in my class, qualitative class. So our analysis begins immediately after data collection. Our multidisciplinary research team developed the codebook first and then generated key themes and sub-themes guided by this codebook. During the data analysis, our team met multiple times to ensure coding consensus among researchers. The second phase is indicator development based on our findings from this qualitative study. Through iterative process among 4 researchers, we came up with 8 themes and operationalized them into 73 indicators associated with successful implementation of farmers market intervention. 73 indicators. In the third phase, a 2-hour-long face-to-face consensus conference was held in November 2015. 14 expert panelists composed of practitioners and experts in farmers market intervention participated in this conference, and the conference had 2 parts. And in the first part, panelists were asked to work in a small group. It was 2 or 3 panelists for each group to conduct a pile sorting activities to sort each indicator into the relevant theme pile. For this activity, we provided them operational definition of each theme along with a set of index card for each indicator. So the picture shows the real kind of this activity. So there are theme card and indicator card, and 2 expert panelists are working together in pile sorting activities. After they were done for the pile sorting activities, these groups also rank ordered indicators within each theme based on their relevance for successful farmers market intervention. And the research team recorded the top 3 indicators chosen by each group of the panelists and assigned the score 3 for the first choice, 2 for the second choice, and 1 for the third choice. And the score from all groups became indicator weight. In the second part of the conference, panelists were asked to individually assign weight score to the themes through an interactive voting process. Panelists received 25 tokens and were asked to distribute all tokens based on importance and relevance of each theme for successful implementation of farmers market interventions. Panelists recorded the number of tokens distributed to each theme on a worksheet, and the score from all panelists became theme weight. The fourth phase is indicator refinement based on findings and feedback from the panelists who were in the consensus conference. 6 researchers worked together to review comments from these panelists and revised language of indicators and merged indicators to create new indicators if they are similar. Especially, we took higher indicator weight when we merged the indicator, and finally, we developed response options for each indicator and mapped theme scores on a scale of 0 to 1. In the fifth phase, pilot testing was conducted with 19 new practitioners in total and 4 practitioners for these farmers market interventions indicators to a certain phase and content validity. We also asked these practitioners about overall impressions, recommendation for improvement, and motivation to use this instrument. So this slide summarizes the process of indicator refinement. So our primary purpose of this refinement was to develop a measure capturing multidimensional construct of community readiness and capacity for successful implementation of farmers market. But at the same time, we wanted this measure to be parsimonious. So we initially developed 73 indicators based on the findings from qualitative study data, and then we could narrow down to 44 indicators based on finding from consensus conference. And we review feedback from the panelists in consensus conference, and finally, we applied 80% of total cumulative indicators weight rule for indicators within each theme, which result in 30 indicators as a finer indicators. And then, and these 30 indicators represented 6 themes. And we named this finer set of indicators as PSE Readiness Assessment and Decision Instrument. So we called PSE READI. So I would like to talk about our finer themes and their associated indicators for successful implementation of farmers market intervention. And I want this to be more interactive, so I will ask some questions. So what influence readiness to implement farmers market PSE project, you think? Anyone want to jump in? No idea? Okay. So we find these 6 key themes for successful implementation of farmers market intervention through our consensus-based modeling approach. So the first theme is community food norms, which can be defined as community perceptions and skills needed to take advantage of farmers market PSE project. And next, logistical factors refers to factors that are needed to coordinate the implementation of farmers market PSE project, such as location, transportation, and pricing. The third theme is networks and relationships, and it is partnership and support system from which practitioner can draw on to implement and support farmers market PSE project. The fourth theme is organizational and practitioner capacity, which can be defined as skills, resources, and capacity of organizations and practitioners to support the implementation of farmers market PSE projects, such as budget, staffing resources, and work plans. The fifth theme is practitioner attitude and perceptions, and it refers to practitioner exposure to electronic benefit transfer system implementation, healthy food incentive programs at farmers market, utilizing farmers market to educate people and practitioner perception of people's use of farmers market and farmers market staff. And the last theme is sustainability and community perception, and it refers to community motivation, community awareness, advertisement, and factors to increase the supply and demand of farmers market PSE project. And now I have second question. I think you can answer to that question now. So which themes do you think more important than others? No idea. Yeah, Mark.
Skills, resources, and capacity of organizations and practitioners.
Yeah, skills and
Organization and practitioner.
who said organizational? Yeah. Any other thoughts?
Logistical factors.
Logistical factors. Fred?
Attitude and perception.
Perceptions. Practitioners' attitude or perceptions. Greg, you want to say
I was
something?
going to say logistics.
Logistics.
Yes.
Any other thought? This is the result of theme weights from our modeling approach. So the organizational and practitioner capacity is the most important theme for successful implementation of farmers market intervention, followed by networks and relationships, and sustainability, and community perception, practitioner attitude and perception, logistical factor. Yeah, you have a question, yeah.
What's the basis for determining this?
Based on the theme weight from expert panelists in our consensus conference.
Opinion.
Yes.
So it's just like the opinion in this room,
Yes.
right? But now it has to map on to actual implementation.
Yes.
But again, remember who was involved, and, that was
Yeah.
through the qualitative data. the
Darcy, we're
expert
gonna get
panel. Yeah, just as remind folks that was through the qualitative data, the expert panel. But yeah, Jared will talk in a minute. It's a Bayesian belief network model, so it's built on the belief systems of what people think is most important.
So now this slide shows sample indicator within each theme and indicator weight. This is also come from the panelists in consensus conference, and response options and supporting direct quote from our qualitative data. I'm not gonna kind of review all these indicators, but I just wanna give you an example. So there are 4 indicators in organizational and practitioner capacity. And one example is to what extent does your, here in your means CHC or OSU, because we target that entities, your organizational or program grant budget have sufficient funds to support farmers market PSE project this year. This is the one example of our indicator for organizational and practitioner capacity. And the response option is 1, from 1, not at all, to 5, extremely. And we also have don't know options. And for this particular indicator, the weight score was 8. And you can see the direct quote from our qualitative data to support this indicator. So it's in hopes that, with the grant being the driving force, that there's funding for a continuation project. So now you can see the kind of connection between our qualitative data and our indicators. Another example from sustainability and community perception, there are 7 indicators related to this theme, and one example is to what extent are there enough local farmers, vendors available to support farmers market in your service area. And our response options are the same across all indicators. 1, not at all, from 5, extremely. And indicator weight score for this this indicator was 13. And then direct quote is part of the reason farmers markets didn't succeed was because we didn't have any vendors. So it's really kind of deeply related. So there are 3 indicators in logistical factors. One example is to what extent is it possible for SNAP recipients or other low-income populations in your service area to get to a farmer's market either through public transportation or by walking. And its weight is 8, and direct quote related to this indicator says, if you don't have transportation, and it's hard to get there. So as Darcy mentioned earlier, our goal was to develop tailored implementation strategies. Our final product of this assessment tool is not a score of readiness, so we are not going to give practitioner an exact score of their readiness, but we will give them tailored recommendation based on the level of readiness so that practitioner can develop action plan and make progress in implementing farmers market intervention. So there are 3 recommendations for each indicator, and they are divided into 3 categories: low, medium, high, based on their level of readiness. And we developed this recommendation initially based on our literature review, and we also incorporated key resources from our CHC and OSU SNAP-Ed partners, and refined the contents based on feedback from 2 farmers market content experts. In addition to this, we are planning to get feedback from 2 national level farmers market content experts and refine based on the findings from our user experience survey. These are our plan. And then Gerard will talk about our scoring system, which seems very complicated.
Okay, so I thought this was a really interesting project to take on. Darcy approached me maybe, what was it, late 2014. This project is about identifying some sort of, is that better? Identifying basically latent attributes, right, which is something that I think a lot of people in this room have experienced doing, but identifying latent attributes that are based on individuals' beliefs and groups' beliefs, as opposed to empirically derived from some data source, right? So this whole process was designed around representing the beliefs of both individuals as well as this leadership group or this group panel of experts. Right, so most of the hard work was done by Unlay and her team in terms of coding all of the qualitative input from the individual practitioners, right? That's a tremendous amount of work. And from that, we had all of these indicators that we needed to sort through and determine what is the relevant theme, and how do we put it all together in terms of how the panel of experts really thinks that each of these indicators might be representative of community level readiness, right? So I'm just going to run through the process really quickly. At the lower level, you see lots of these ovals here. I knew I was going to do that. There we go. Yeah. I'm tall enough, you can see it. So at the lower level are each of the individual indicators. So Unlay gave a couple examples of the indicators, one under practitioner capacity, and I think the other one was it under logistical factors. So each of those indicators were ranked as Unlay described, and we assigned a arguably arbitrary score to the top 3 indicators from each of the participants in the panel, right? And the total score that is assigned to each indicator was used as the overall indicator score within that theme, and that's what loads into each respective theme. So each indicator scores importance weight. All of the indicator scores importance weights add up to 1, and each individual indicator's relative proportion is the total of the weights that were assigned by the panel for that indicator divided by the total of the weights for all of the indicators within that theme, right? And then for the second level here, this was the chip exercise where each participant in the expert panel had 25 of these poker chips, and they allocated them in terms of their internal beliefs about the relative importance of these things, much as you guys did here in this little exercise, right? You were sort of internally comparing the relative merits of each theme. So how do we put all of these weights together? Well, it's a relatively straightforward hierarchical scoring scheme, right? Each of the questions, as Unlay demonstrated, is essentially, most of them are Likert type questions that range from not at all to extremely or what have you, right? So we assigned a score of 0 to the lowest answer, not at all ready, and a score of 1 to the highest possible answer. And from that, we applied 2 sets of weights multiplicatively, right? The first weight was the indicator weight within each theme. So that might be the 0.18 for one specific indicator, 0.36 for another specific indicator. You apply that indicator weight, and you also factor in the overall theme weight across all themes to come up with this, what we're calling the weighted indicator score. From the weighted indicator score, we compute what we call a final indicator score, which is basically what is the maximum possible weighted indicator score. So if you had answered extremely on that question, how many of these weighted points are you getting? So that's the maximum possible, and you subtract off your weighted indicator score. So that basically tells us how much area of improvement you have, your community has on that specific indicator. Okay? And then from that we compute this theme score, which is the sum of these final indicator scores within each theme, and all of the themes get combined together to form this overall readiness score. And as Unlay mentioned, the overall readiness score is not something that we use directly in interacting with the various stakeholders, especially practitioners, but it's just something that's used as an intermediate calculation and generating recommendations on each respective on the most relative indicators for your community. So this is an example of one specific theme where we have some simulated responses for 4 indicators underneath this organizational practitioner capacity. You could see the overall theme weight was, as she showed on that slide with the arrows, this was the most important theme. The overall theme weight was 0.22. And then within this theme, we had 4 indicators. And the weights for those indicators are given by the next column over. Right? So you can see the first one, to what extent does your organization or program grant budget have sufficient funds to support farmers market PSE projects? So that one was the highest weighted indicator within that theme, and it got a score of 0.42. So let's say somebody answered sometimes on this Likert response for this indicator. That would have gotten assigned a score of 0.5. So basically we're just multiplying these things together, right? 0.22 times 0.42 times 0.5. Right? So that gives us a weighted indicator score of 4.62. We multiplied that by 100, right? So that's the weighted indicator score. And the maximum possible indicator score would be the indicator score that you would have achieved if you had answered this question as extremely or perfectly. You got a score of 1 on that indicator, right? So subtracting those 2 columns gives us the area of improvement, which we label the final indicator score for each specific indicator. So we do that across all the themes, and we have this sort of weighted final indicator score, which is a representation of importance weighted area of improvement on each specific indicator. And then we rank those in descending order and pick the top 3 indicators as the areas of recommendation for that specific community. And here's an example of it just sort of simulated here. So let's say a practitioner goes and does this panel, and it results in recommending these 3 indicators. First of all, integrating farmers market PSE projects within your work. And it's just, so, basically garnering financial resources to make it possible. The second specific recommendation would be to summarize the outcomes of your farmers market customer survey results. And the third one might be to identify potential partners, coalitions, and networks in your service area to collaborate with. So let's say they make progress on 2 out of these 3 indicators and come back after a year and redo the panel, right? So they might have made progress on the latter 2, but not really done anything to improve their community's situation on this first one. I'm sorry, I had that backwards. They might have made progress on the first 2 and then not really addressed the third recommendation, right? So if they came back and they redid the survey, they might have answered these questions in a different way, such that this weighted final indicator score would look differently for the ones that they had made improvements on. And in that case, they would have had a different set of recommendations in the second go-around. So I guess the other thing that was really interesting is we did in this step 5 in our preliminary work, there were 5 respondents that we had these indicators, these theme weights calculated among. And they were all over the map in terms of what was their readiness on each specific theme. So we're going to be doing a pilot study. We are doing a pilot study where we'll be able to more objectively and get better data on how much variation there is. But even in just 5 communities, there was a very wide amount of variation on specific themes at which communities had better or worse readiness. Okay.
All right, we're close to being done here and then opening it up for discussion. So why do all this? Because it's been a very long process. Why does this matter? And I think what Jared just said is why it matters. The reality is that every community is different, and generic recommendations are not necessarily going to be that helpful, perhaps to nobody. But again, to the point that we're ultimately focused on is really in communities where there's a disproportionate burden of obesity and diet-related health conditions. Probably many folks have heard of the idea of precision medicine or precision science. And I think what we're doing is the corollary of that, but applied to community level. This idea of localized intervention implementation strategies. So as far as we know, this is the first attempt to understand the factors of successful implementation of the PSE interventions, the 4 that we're looking at, and operationalizing them into measurable outcomes. Our process of collecting the data ideally created a more relevant, more useful tool, and the fact that we engaged people across the state in the process is likely to increase utilization now that we're at the stage of utilization. The third point there around the idea that, if you're going to be successful in implementing PSEs, as you saw with those 3 recommendations, it's important to be given the right information to move forward at the right time. So meeting people where they're at and giving ideas. A lot of people, especially in SNAP Ed, who've never done PSEs and they weren't trained to do it, don't even know what to do. So some of the feedback we've heard, even just taking the assessment, is like, oh, I'm unpacking that black box. Like, this is how I could slowly move forward. Maybe it is starting to get funding in our budget for me to spend time doing this for 2% effort, if that's what it is as a first step. And then lastly, and really probably most important to me, is this idea of equity. And the idea that we need to use tools like this to guide how we deliver resources to communities, such that the communities that have the least readiness and maybe the lowest capacity need to be given more resources to get up to speed to be able to take advantage of the potential benefits of these evidence-based interventions. In terms of our next steps, because the scoring process is very much an interaction, we felt like it was important to create a tool that could be delivered online. And so we're working on a website that will allow people to take an assessment as an individual. We'll also allow you to take an assessment as a group, because this is a community level change project, and in reality, we hope everybody would be taking it as a group and building on a lot of other community readiness models. In addition, they'll have the tailored recommendations for action. Our website will also have a compendium of resources that will sort of underpin our recommendations, but a lot more will be available on there. We've done videos from practitioners across the state to try and tell their story, to put the face to what does it mean to do this kind of practice, and not the success story, because we hear this great, place in, Produce Perks is a good example. Cleveland is a leader in that area, and places in rural Ohio look to us and say, there's no way I could do that. So we want to see some of the early steps in those videos. And then we're moving toward probably not until at least the fall of this year, next year, developing learning collaboratives so practitioners can work together to share lessons and hopefully optimize their practice. We'll be piloting this in 17 counties in Ohio this spring and summer, and then our goal is to further refine, and then it will be available for statewide dissemination. We have a lot of requests for national dissemination, and that's ultimately our goal. So I want to close with one little video from right here in Cleveland, and this is going to be one of the videos that will be on our website. I don't know if you guys, if we could turn the lights off maybe for the video. I guess I can right here. It's not our final video.
This is the Gateway 105 Farmers Market.
You can go full screen.
It was established by the Famigos Foundation in July 2011. It's a community-based market. Most of the vendors actually grow or produce a product within 5 miles of the market. It's really fun and homey. People know each other's names. They talk about health issues. They talk about family issues. They're supportive. It's a nice community-based farmers market.
Have a good variety of produce. I like to support the mushroom people. So I like getting fresh mushrooms, and actually have bought a starter kit for them, so I was able to grow my own mushrooms last year.
A lot of people told me that they feel better, that it tastes radically different. Or the best thing I think is hearing that it reminds them of their childhood. Like some of the older people, oh my God, there used to be a fruit tree on every corner or whatever, and now that just made me think of that. And it's cool to bring them back to a good time. It's more of a mission to me more so than anything. I come out here to try to raise awareness and just build a base of people that know what's good and know where to get it from.
The thing that makes me really happy about the market is the connectivity that happens. I watch some people drive up and they kind of do the look around just to see who's here, and they'll stop and they'll get out and they'll come and greet somebody that maybe they haven't seen since they were in high school, or they haven't seen for the whole summer, and they may or may not make a purchase. Well, I really like having the opportunity to provide a space for them to do that.
Probably the coolest farmers market that I go to, simply because of it's all communal based. Everything is people from the area and providing for the area, and that's something I'm really big on.
We're ready to go ahead and open it up for questions. And I'll have, if Jared and Unlay want to come on up, that would be great. Oops, I got to figure out how to make that stop real quick.
Produce Perks.
And before we go into questions, I want to extend my thanks. I'm Cleve Gilmore, the Dean of the Mandel School. And it's been a fascinating presentation by Drs. Lee, Friedman, and Dalton. It's great to see the collaboration among the different specialties and also the impact that's happening in our community. I know that we have a number of doctoral students here who've been inspired by the methodology, and I think have some ideas about what they might be doing going forward. So thanks very much. Thank you. Okay. And now we're going to turn it over for questions. And we hand it over to the person who's going to handle the mic for the questions.
Oh, let me just say, this is just too close. Let me just say thank you for all the detail you provided about your process. So often in qualitative, studies, you don't get the whole meat of what people did, and you can see the work that happened. And my question was that, will there be a different readiness scale for the food and childcare? So there's be different ones. Do you suspect that any of the factors would be similar across all the types of programs?
Yeah, there are some similarity in terms of themes across those 4 nutrition-related interventions. For example, I think we found organizational and practitioner capacity is kind of key themes across all these interventions. And some community perception themes also kind of was prevalent across those 4 interventions. That is kind of my memory at this point. Yeah.
I'll just add on to that. That was a research question we had. This idea is these are all food environment interventions. You could say broadly in a generic category. So is it that there's one set of things that apply, sort of meta concepts, or do you really need to go down into the specifics of each one? And I think even though there are a few things that transcend, there are very different parts in each of those. And I think, again, that's a real asset of this tool, where we can be very specific, more precise in terms of guiding intervention development.
So I'm just kind of curious. You had your expert panelists, and I'm just kind of curious what kind of experts make up that expert panelists. Are they community experts, farmers markets experts, dietary experts, just in general?
Yeah. Great question. So our expert panel included all the groups that you just mentioned, and actually we had a different expert panel for each of the 4 PSEs, because it'd be different experts. People that understand childcare may not understand farmers market. So people who work in SNAP Ed, work in creating healthy communities, who operate farmers markets, who understand community level interventions. There were no researchers in the expert panel. We were there as observers and recorders, but we did not engage in that voting process.
I take this that you answered everyone's questions. You made it perfectly clear, so there are no questions. But thank you very much. Let's express our thanks to our presenters.